it's my pleasure to introduce our two speakers that will be involved in the debate today. And the topic they are going to talk about, obviously, is in the program here, surgeon versus oncologist, who should decide resection in metastatic disease. Dr. Chee is our very senior oncologist in the National Cancer Institute. She graduated from UCL London before she went on to do her residency and fellowship in Mayo Clinic. She's currently also one of our anchor of HPV and GI cancer oncology in ANSYS. And she will be debating against Professor Clarisse Eveno from Department of Surgical Oncology of Lille in France. And one of her area of specialty is actually in peritoneal resection, and she's also the PI for the first RCT using pipette to treat gastric peritoneal metastases. And she's also a member of the board of RENAP, French network on treatment of peritoneal disease. Without further ado, we will look forward to an exciting debate from the two of them, 10 minutes each. We have a poll after that, and they've agreed that there'll be no rebuttal. Okay, Dr. Chee, please. Interesting to have two females debating on this topic. Okay, that represents equality as well, and diversity.
Thanks, Alfred. Thanks, Jeffrey, chairpersons. Thank you, Jimmy, for giving me this topic. I have to wear the hats of my many, many colleagues here, and I'm feeling a little bit outnumbered. I think I'm the only one of two medical oncologists here. So today I'm going to wear the surgical hat, and I'll be debating, these are my disclosures, who should resect in metastatic disease? So surgeon versus oncologist. I'm wearing the surgical hat for this short period of time. I'm going to give you 5 reasons why the surgeon should resect in metastatic disease. Number 1, never allow an oncologist near a scalpel. I chose oncology for a reason. I love my chemotherapies. I love the drugs that we give our patients. I did not want to be in the OT for the rest of my life. And we know surgery, if you look at the origin of the word from the Greek word is chirurgia, according to my husband, that's how you pronounce it, and it's handwork. So if you want to have best outcomes in resection, you want to be in the hands, literally, of the surgeon. Now, we know in the hands of the surgeon, you have best outcomes. So that's my second reason. I'm going to show you some evidence about this. So last year in ASCO, this was the Japanese study. We were waiting for these results, JCOG 0603. They looked at patients with resectable metastatic colorectal cancer, and they randomized 300 patients to just observation, so just surgery alone, followed by observation, and then chemotherapy in the other group for 6 months. And it showed that although surgery alone did not prolong the disease-free survival, but there was no difference in overall survival. So, in conclusion, for small liver metastases less than 3 centimeters, surgery alone is enough. Don't give chemotherapy. You're not going to change overall survival. Although the disease might relapse a little bit later, you're exposing them to unnecessary toxicity from chemotherapy. So here, surgery alone. The second thing, I think my opponent here will be very familiar with this, the Protégé 7 study. Again, metastatic colorectal cancer with peritoneal-only mets randomized to cytoreductive surgery plus HIPEC versus cytoreductive surgery alone. Again, no difference in overall survival. So yay, cytoreductive surgery alone wins for this group of patients. No need to expose to HIPEC where you have actually grade 3 or worse adverse events later on. Now, reason number 3, the surgeon's knowledge in resection is unparalleled. I don't know how you guys do it, but you can tell me if you're going to get good surgical margins, the R0 resections, lymph node dissections, PCI scores, the reference to neighboring structures. You're going to reconstruct. You're going to get another surgeon involved. That's beyond me. I take my hat off to the surgeon with this unparalleled knowledge. And reason number 4, you are the masters of anatomy. You have a book, The Bible of Anatomy, by a surgeon. Henry Gray was an anatomist and a surgeon. And we know, I think several of us might have this book on our shelves. But yes, this was one of the Bibles of anatomy in medical school. And last but not least, your reputation precedes you because you even have your own show. Look at this. I think it's 18 seasons running all surgeons, you've captured the world that surgery has to be in your hands. So hopefully I've convinced you that a surgeon should decide resection in metastatic disease. Thank you very much.
Thank you so much for giving me the opportunity to fight against surgery. And I think that the oncologist should decide the resection in metastatic disease. So you are doing a standard laparoscopic colectomy, you are doing some surgery, and you discover some peritoneal metastasis here. So the local disease becomes a systemic disease, and you have to perform some systemic treatment to control the microscopic disease and get some response and control the toxicity of the chemotherapy. And maybe bring to surgery the patient. So first you have to make the best choice for the type of chemotherapy with the knowledge of disease, maximal response rate and best survival effect. But also you have to lower your toxicity and the number of cycles of chemotherapy. So you have to know the disease that you will treat. And if you look at this study, it's a pooled analysis of 14 randomized, controlled randomized study on metastatic colorectal cancer. And you see that there's a doublets and triplets of chemotherapy with targeted chemotherapy. And you can see here the median overall survival. So patients with lung metastasis achieve 25 months of median overall survival. For liver, it's 19, and for peritoneal metastasis is 16. So for peritoneal disease, there is a lower survival comparing to other metastatic sites, but it's not negligible. When you look at this study, this is almost 300 patients with gastrointestinal cancer of various origin, more than 200 stage 4, and you see that the amount of ctDNA detected in plasma correlates with the stage. But it's also correlating with the tumor burden, except for peritoneal disease. So this is a poor biomarker in this type of metastasis. So I will introduce some old concepts, the fact that we need some maximal response to go to surgery and also to have some better survival. This is an old publication from a French group, from René Adam, published in 2004. And they treat patients with more than 3 liver metastases. And we can see that chemotherapy can allow to select patients. This is a very old concept, but we should not operate patients with progressive disease under chemotherapy. Another old concept from the same group is that patients with chemotherapy can bring non-operable patient to surgery by downsizing the tumor and to achieve a non-negligible survival. It's an old concept, but it's still up to date because when you look at the CARO5 study with the last week at ESMO, we just figured the first results. And for initially unresectable colorectal liver metastasis, assessed by liver experts panel of surgeons and radiologists, initially and every 2 months, for patients with from RAS and BRAF wild type, when you compare doublet of chemotherapy with bevacizumab and with panitumumab, we have some positive findings because we can see that with the panitumumab, we have a response rate that is increasing and a median depth of response also better than with bevacizumab. So this is positive findings. We can have some response. But the study is negative because the secondary resection rate is the same between the 2 groups and also as the median PFS. So the improvement of radiological response is good, but this is the same survival rate. So we have to adapt our medical criteria to patients' expectation. We also have to lower our toxicity and the number of cycles to bring patients to surgery. When you look at this study, if you increase the amount of chemotherapy, when you use triplets of chemotherapy with bevacizumab instead of doublets, you increase the survival, but you also increase the toxicity. And toxicity, so I'm a surgeon, I don't really understand this table. So toxicity can only be predicted by oncologists, and you have to adapt the dosage and the number of cycles. So you're good. So number 2 is, can we bring patient to surgery? Is the patient fit for surgery, and can we remove the disease with low postoperative morbidity? When you look at this study, it's a study from France. So it's a group from Olivier Gléen, and you see that there is more than 600 consecutive cytoreductive surgery, and it was a patient operated between 2009 and 2014, and the clinical pathway started in 2012. So you can see here the clinical pathway with a very good drastic patient selection with radiological work that is performed just before cytoreductive surgery, preoperative evaluation of the nutrition and renal protection, pain management, prevention of complication, and also early detection of complication. And when you start the clinical pathway, the number of cytoreductive surgery are increasing every year, but the number of major complications is decreasing, and the morbidity, the mortality is almost null after we just select the patient and take care of them carefully. So as you know, the morbidity influences the survival. This is a study on more than 1,000 cytoreductive surgery and IPEC for peritoneal disease from various origins. And you can see here that there is a linear correlation between overall survival and the morbidity, the Dindo score. So how can we just lower our postoperative morbidity and mortality? We used our national French database for recruiting 10 years of patients of more than 7,000 cytoreductive surgery and IPEC. And we can say in our practice that major morbidity is 44%, and the 90-day mortality is 2.6. The failure to rescue rate is 5%. But when you're trained and you're working in an expert center with more than 35 procedures performed every year, you decrease the 90-day mortality and you divide it by 2 the failure to rescue. The risk factor for a 90-day mortality was age and comorbidity score, so we have to do a very careful medical selection, and oncologists are doctors. But we also have to decrease our morbidity and work with a team of experts. So oncologists as also need to address patients to expert centers. So the oncologist should decide resection in metastatic disease because they know the disease. They can choose wisely the drugs and the number of cycles and, to control the toxicity. And there is a major importance of preoperative patient evaluation and addressing to expert centers. So the oncologist should decide resection in metastatic disease, but surgeons are oncologists who operate patients and have to know when not to. Thank you.
Okay, thank you very much for the very exciting and interesting debate between the two ladies. Reversal of role. We've agreed there's not going to be any rebuttal, so there's only going to be one poll at the end of this. And are we going to show the slides? Yeah. So if you could log in to the Slido with the code HEX 2864799, it'll be interesting to share your decision regarding whether the surgeon or the oncologist should be the one that's deciding on resection of metastatic disease. And I think the result won't be surprising.
Perfect.
A very balanced group.
Perfect. We won.
Yes.
Okay, so it's quite clear, the verdict is out. It's definitely joint decision. And it's important because I think we can't be everyone that knows everything. It's important to have the balanced view, understanding the disease, how to use systemic therapy to improve the chances of survival and resection. And of course, the oncologist also relying on us to understand the anatomy and see whether it's safe to proceed with resection. So quite clearly, based on this particular topic, we should recommend that all centers have a multi-dip approach to managing this kind of conditions, okay?
And the surgeon made the best case for the medical oncologist.
Okay, so a round of applause for the two ladies for the debate. Thank you very much, Dr. Chee and Dr. Eveno.